Welcome, everyone, to the International Childbirth Initiative 12 Steps to Safe and Respectful Mother-Baby-Family Maternity Care webinar series. My name is Michelle Scarotherian, and I'm the Executive Director of ICI. ICI is an implementation and quality improvement process that strives to achieve the 12 steps for safe and respectful mother-baby-family maternity care through self-evaluation and a reflective process at the facility level. ICI is also a global resource network of facilities who are striving to share their learning and improve the provision of care. ICI was created through the joint effort of the International Federation of Gynecology and Obstetrics and the International Mother-Baby Childbirth Organization. And it includes 20 partner organizations, actually now 30 partner organizations, and continues to grow. And we're open to all birthing facilities who are willing to commit to delivering safe and respectful mother-baby-family maternity care. We're very pleased to have two presenters with us today, representing ICEA, Bonnie Katz, and Elizabeth Kurtz. The International Childbirth Education Organization was formed in 1960 with two principles in mind: the freedom to make decisions based on knowledge of alternatives, and family-centered maternity care. ICEA offers 3 certification programs for childbirth educators, the doula program launched in 1997, and then in the early 2000s, they separated the birth doula and postpartum doula programs. And in 2018, they've expanded it to include the first 1,000 days as part of the postpartum doula program. And their certifications remain valid for 3 years. Today's step is step 8, implement measures that enhance wellness and prevent illness for the mother-baby-family unit. It will be presented by Elizabeth Kurtz and Bonnie Katz. Bonnie Katz is the past president of ICEA. She became an ICEA certified childbirth educator in 1993 and was certified as a doula in 1997. In 2005, she became a registered nurse. She now leads workshops across the Western United States and internationally as a trainer for ICEA childbirth educators and birth doulas. Elizabeth Kurtz began her journey in maternal health over 20 years ago when she became a prenatal educator, giving her the opportunity to merge her background in public health and her interest in maternal health. She is the current president of ICEA. We're very pleased to have them both with us today. So now I will pass this over to Bonnie Katz.
Hi, everyone. Let's just go over one more time what step 8 is. It is the promotion of wellness and prevention of illness are the foundations of improving maternal and newborn health. To implement educational and public health measures that enhance wellness and prevent illness and complications for the mother-baby. This dovetails very nicely with ICEA's care, family-centered care, and many of the steps of ICI overlap. Step 3 talks about a collaborative care model. Step 6 promotes evidence-based care. And step 7, avoiding harmful practices. These we'll touch on each of these within the context of step 8. Foundational to good, healthy prenatal care and care throughout the childbearing years is good nutrition, clean water, and clean and safe environment. Good nutrition is foundational to a healthy pregnancy. Displaying pictures of various foods is one way to promote a healthy diet. If you teach antenatal classes, having snacks out can be a way to give people good examples of providing this nutrient or that nutrient. I've even seen this picture used to promote understanding of different types and sizes of breasts and even breast anatomy, with the individual grapes being the little milk sacs or alveoli and the stems being the milk ducts. It's just kind of another subliminal message of this is good nutrition. These are healthy things that you can use.
Okay, I'm going to go ahead and start talking about water, sanitation, and hygiene. So we want to make sure that water, sanitation, and hygiene are something that we include in maternity services. It's not always thought about when we are looking at what are the most important things for our families. But we need to make sure that we ensure promotion and provision of clean or boiled water, clean toilet facilities, and a clean environment for all birthing settings. Working in lactation, boiled water is something that does come up a lot for me, even in the United States, where we assume that there is clean water, but that is not always the case. So let's go ahead and explore this just a little bit more. So promotion of hand washing and good hygiene is also critical when we're thinking about the clean water and the safety and all of that. We know from being in this pandemic that people are much more aware of how important it is to have good hand hygiene and how important it is to have good sanitation. Prior to that, I think it was not something that we had really approached and thought about as much as we should have. So by teaching our patients, our clients, the people who we are working with, to always make sure that they are washing hands, that they have running water, and that they consider how germs and bacteria are transferred is something that is critical in our teaching. And one thing to know with, as I said, running water, not everyone has that, but there are ways to get by with that, even if you don't have the traditional, as we think of, plumbing. Even if you have a source of water that you can run, like a bucket that you can dump and pour that over the hands, is going to be a better option than somebody who's dipping hands into a stagnant water source. So, so thinking through all of the different variables in the areas where you're teaching. Disease prevention. Now, this also comes in when we're talking about hygiene and sanitation. So we need to provide education in and access to methods of disease prevention and treatment for mother and baby. This is going to be different in various areas, but we need to include things like malaria, syphilis, hepatitis B, toxoplasmosis, HIV and AIDS, along with tetanus, toxoid immunization. And so as I said, it varies from area to area, but it doesn't mean that because you are in one area that you can assume that some of these aren't critical or important to you. HIV or AIDS is one of those that I'd like to point out. In the United States, a lot of times we don't think that we have to worry about that. We don't think we have to talk about it. And yet in working with the medical director in my area, who is the state medical director for HIV and AIDS in relationship to pregnancy, she is very adamant about testing for HIV during pregnancy, because she said that about 5% of the patients who she sees did not know that they even had a risk for HIV. I personally was kind of trying to avoid it with my last pregnancy, but she caught me with working in a hospital. You are subject to bloodborne exposures, and so getting baseline data would be a good thing to go. And so I did go ahead and test for that. But she finds that she has to have that argument frequently, because it is something that people don't think that they have any possibility that they could be exposed to. Hepatitis B, same thing, syphilis. We just don't always know what we are exposed to. And so being aware of that, and in our teaching, just bringing it up and having the conversations is something that's going to be important to do. So going back to the HIV treatment and care, if that were to come up, you want to have clear, non-discriminatory policies and guidance for the treatment and care of HIV positive women and their newborns. And you want to follow national guidelines on prevention and treatment of HIV in pregnancy, including prevention of transmission and early treatment of HIV positive newborns. This is something that we in the lactation area come up against very frequently when we talk about guidelines for breastfeeding, because they do vary significantly in different countries. And so you want to make sure that you are following those guidelines and presenting that information in a way that is consistent with what happens in your area. So HIV testing during pregnancy, as I mentioned, is recommended. Opt-out testing policies encourage more women to be tested. So what we want to do is make sure that we're giving the education so that when that testing is done, or whether that decision is made or not made, that there is appropriate decision making, so that we can be sure that the reasons for or against doing it have been really clearly thought out. So as I mentioned with HIV and breastfeeding, HIV positive women can safely breastfeed without transmission to the newborn and are encouraged to do so in many settings, but referring to national policies for those recommendations, because as I said, they do vary from where you are. And it is very specific to exclusive breastfeeding versus non-exclusive breastfeeding. And so you have to be careful that you're weighing those benefits and risks and knowing how it can be safely done, so that you can make the guidance based on that. So reproductive options. We always want to provide education in responsible sexuality, family planning, and women's reproductive rights, as well as access to family planning options and youth-friendly services. So reproductive options can be very different depending on where you're living, country to country, and even in the United States, from state to state. And I know that varies in other countries too, from territory or from region, whatever it is, that the options do vary depending on what is set up and is in place. And so knowing what is available, what you can do appropriately, how you can guide and educate people is what you want to be thinking about with the various reproductive options. Okay, education. Provide supportive and culturally competent prenatal education based on evidence and antepartum, interpartum, postpartum, and newborn care that address the physical and emotional health of the mother and baby within the context of family relationships and community environment, including women who experience perinatal loss.
So that's a lot in step 8. Let's take a look at what these terms really mean. What is supportive care? What's culturally competent, evidence-based, and physical and emotional health, and including information on perinatal loss? Let's take a look at each of those. This is a diagram that ICEA has had literally for decades. It shows who the primary decision maker is when it comes to prenatal care, postpartum care. It's that pregnant person. They're the central decision maker. But it also illustrates other people that influence those decisions, that may give advice or encourage a decision one way or another. But again, they support the woman, they give advice when asked, but they are not the main decision makers. Ideally, all of these people act respectfully, even though, remember, step 1 of ICI is to treat all people with dignity and respect. And although the emphasis there is on the pregnant woman, all of these people will make her decision-making process much more easy. I don't want to say easy, but maybe with less conflict, if she is able to do that in a supportive, kind-hearted environment. Culturally competent care does not mean that you know everything there is to know about someone else's culture. It's always appropriate to ask. You might say, do you mind if, or is it all right that I do this? Asking is a way of showing respect. In a lot of ways, people consider, I've heard the phrase cultural humility, and I like that. I think that is the right attitude to approach it with. Some things to consider are dietary restrictions. Again, if you're doing a class, either antenatally or postpartum, and you're offering snacks, you want to make sure that those are appropriate for the person that you're serving. You may also want to consider social standards. In some cultures, there are topics that aren't okay to discuss in mixed company. You may want to consider things like their reading level or their poverty level. All of those things play into our culture. Evidence-based care is really important. And I believe it was step 6 that really talks and goes into detail about evidence-based care. But just as a brief reminder, kind of a recap here, the 3 major components of that are clinical expertise and research, but also the preference of the pregnant person. Those are the 3 main components of evidence-based care. We need to be educating the family on what that is, and we need to do so in a context that allows them the freedom to make those decisions, whether or not we agree with them, but then not just allows them to make the decision, but actually encourages them to think through their options and make the decisions that are right for them. The next few slides are based on a diagram that was, Brenda Barr is a doula in the United States who correlated birth needs with Maslow's hierarchy of needs. And we've taken that and adapted it a bit to fit into the International Childbirth Initiative. So the center circle is life. Parent and baby are alive with access to emergency care if needed. And that's basic. We need to have live people in order to help them. But I'd like to share a quote with you from Dr. Neil Shah that he said in the video entitled Growing Families with Dignity. He said, "Survival is the floor of what people deserve. We should be aiming for the ceiling, not just safe, but also supportive and empowering care." And that really is a good picture of what we're trying to communicate with this diagram. So the center part is they're alive, but the next step is for them to be healthy. So not just that they survived, but they are as healthy as possible. And health includes both physical and mental health. Trust. So often when we talk about that, we think of the patient or the family trusting their healthcare providers and the other healthcare workers around them. But it does need to be a two-way street because it does need to be respectful care. So the healthcare team needs to also be respectful of the family. That's what's going to create the environment for them to feel free to make the decisions that are right for them. And here comes esteem. Esteem builds right on that trust. You have to have that trustful relationship. And when you do, and as the family explores their options and they make decisions, they feel empowered. That's part of becoming an adult. It's part of becoming a parent, is making decisions and having those decisions respected. And again, our big circle here is hope. Hope is a little word with a lot of meaning. It means that you have desires and a hope for the future. You're looking forward. And that is even if life has dealt you some disappointments. Even if a child has been born with a disability of some kind, or if there has been a loss of that child, there's a place for grieving and grief, and that's necessary. But hope says you don't have to end there, that there is going to be a tomorrow that possibly brings some better things your way.
Okay, I'm going to go ahead and talk about mental health, which segues right after Bonnie's discussion about all of that hierarchy and where we get to. And hope, ending on that hope, that is such a good way to be guiding and gearing when we're working at mental health or looking at mental health. So we have a few different areas that we'd like to discuss within the perinatal mental health. And the first one would be the baby blues, then depression and anxiety, along with birth trauma, and kind of exploring the differences between all of those. So baby blues, this happens to the vast majority of people who have gone through such a hormonal change of pregnancy, birth, and postpartum, along with lack of sleep and all of the other things that come along with having a new baby. Typically, it happens within the first 2 weeks postpartum, affects most people. I've seen statistics on this everywhere from 70 to about 90%. And then the contributing factors, as I said, the hormonal shifts, the fatigue, and the emotional adjustment to motherhood. When I'm teaching prenatal classes, I generally like to tell my story about baby blues, and that about 5-6 days after my youngest was born, I sent my husband to the store to get groceries, and he came home with mostly everything okay, but he did indeed buy the wrong type of packaging for one item. He brought home a 2-liter bottle instead of cans, and I cried for 45 minutes over something as simple as the wrong packaging for an item I had sent him to the store for. And so that's your baby blues. That's where you just kind of can't quite get through that initial adjustment, or you just have some challenges with your emotions, but it's transient and it doesn't last very long. Okay, so let's move from the baby blues, which is common, very common, and one of those experiences that typically doesn't have too much impact in the long run, and move into the perinatal mood and anxiety disorders. And in the past, we typically called that postpartum depression, but have really moved into the PMAD, perinatal mood and anxiety disorders, because it's more common to have other types and not just the depression of that. So sometimes it occurs during pregnancy, or it can happen within that first year postpartum. So there is a long window when this can present itself and can become something that family is dealing with. Some common symptoms are irritability or anger, anxiety, problems eating and or sleeping, problems bonding with the baby, or feeling out of control. And one of the things that we talk about, I sit on the perinatal mood and anxiety program in my area. One of the things that we talk about the most is that the mom who presents looking very put together at all of her postpartum appointments, or even prenatal appointments, is someone who needs to be explored a little bit more, because when they are very put together and everything seems perfect, we need to be looking at the OCD end of things, the obsessive compulsive disorder, which is more common than depression. And then also, if the person is reporting that they don't feel like themselves, that's a big trigger sentence right there. I don't feel like myself. That tends to be a little bit more the anxiety, irritability end of that spectrum. Okay, birth trauma. Birth trauma, it can be a very big thing, and it's something that has not always been explored or discussed in the past in as much detail as it should have been. Oftentimes, it comes from a perceived lack of communication by the medical staff, or with the medical staff. And let's go with that perceived word right there. It doesn't matter what the staff did, it's how the person who is on the other end of it perceived it and what they felt like happened. So this is a lot has to do with that informed decision making, and then helping them to understand and adjust expectations of the birth experience. There can be fear of unsafe care, and some of that comes legitimately because there is unsafe care, or they might have heard things about their area or where their options are for their birthing. and sometimes it is just because of experiences that they've had in their past. So it really boils down to helping people to understand how to communicate and how to talk with their care providers. So some of the things that really do help or to impact with the birthing trauma is that lack of choice regarding routine medical procedures. And so when we are educating, when we are working with our families who are going to be going through the birthing process, we want to really help them understand what choice is possible to make decisions and make changes, and what things are going to be a little bit harder, and how you can communicate that with their care providers. Sometimes it is just wording. And an example I typically, or yeah, when I'm talking about birth choices and interventions, one of the things I really like to rely on to explore this, or to help them to get to this decision making, is to talk about IV placement, because an IV is a routine medical procedure in almost any hospital setting, and yet it is something that doesn't have to be done. I understand the reasons behind why it's oftentimes something that nurses feel more safe when it's in place. So we use the word delay rather than avoid in teaching them how to communicate with their care providers. So by teaching them to say, let's delay this procedure for as long as possible, or until this happens, or whatever, rather than saying, I will not get an IV in, it's going to have a difference in how you are approaching that whole delivery process, and help to give a little bit more choice and a little bit better communication and collaboration. Now, an issue that is a little bit harder is the lack of continuity of care providers. And in some settings, it's very easy to work around that, and in others, it isn't. But helping the people who you are working with to explore that, to be able to talk to their main care provider so that they can understand how that they can work with other providers should that person not be there at the time, is going to help with that. And then care should be based on delivery outcomes. And I don't even feel like that should have to be said out loud. And yet it does, because sometimes care providers will get very much into their routine and the way that they do things, and it's always done this way thinking. And we really need to go then back to the individual person and what is going to be the best choice to make for this individual family based on their situation. Okay, so providing care during humanitarian emergencies. This is a very different topic to think about, because this is not routine. This is not something that is the standard that we're going to expect to experience. But approximately 5 million pregnant women were impacted by a humanitarian emergency in the year 2018. So an example of that was infants born within 30 miles of an armed conflict were nearly 8% more likely to die in their first year of life than those born in the same region during years when there was no conflict. There are a lot of things that are going to impact that. And one of the biggest things is going to be that continuity of care, and then working with care providers and having all the resources available. But another is going to be maternal stress during that event, where in cases where the conflict was higher intensity, meaning more than 1,000 people were killed in combat, an infant's chance of dying was 27% greater than it would have been during that peacetime. And that can even go back to the slides that we had on hygiene and sanitation and water. Those could have an impact in that area as well. Okay, perinatal loss. A little bit on perinatal loss. Miscarriage is the spontaneous loss of a fetus before the 20th week of pregnancy. A stillbirth is the spontaneous loss of a baby after 20 weeks of pregnancy. And then neonatal death is the death of an infant in the first 28 days of life. And I remember when I first started working in perinatal education and care, and I never wanted to talk about these events because I wanted to gloss it over, that it's everything's going to be okay. We're always going to have good outcomes, but it's not the reality. And so we need to be prepared to discuss these things and then also help families to make decisions on what they can do to make it a better event for them if this happens. So when we look at perinatal loss, infant mortality is that death of an infant in the first year of life. And when you look at this map, you can see that there are huge differences depending on regions and areas. Where you live is going to dictate and is going to impact that infant mortality. And so when working with people, we want to make sure that we really are aware what resources are out there, what things are available, what can we do to support these families should this happen, but what can we do to protect and to decrease wherever it is possible that we can make those changes, where we can implement practice changes, whatever it is that we can do to help support and make change.
So just a recap of step 8, it's to provide supportive and culturally competent prenatal education based on evidence and antepartum, interpartum, postpartum, and newborn care that addresses both physical and emotional health of mother and baby within the context of their family relationships and community. And that includes women who experience perinatal loss. And maybe we should not just say includes women, but men as well, anyone in the family that experiences loss. I would like to make a point that education, when we talk about that, so often we just think about didactic education. I'm dispensing information, but real education is presented in a way that allows people to absorb and integrate what you're teaching. So I think we need to make sometimes a distinction between just dispensing information and truly teaching other people. Discharge planning, another part of step 8, is should be adequate, giving people knowledge of what to expect. We hear a lot about birth plans, but increasingly popular is the concept of creating a postpartum plan. And this will change greatly between cultures. Some cultures already have a supportive environment kind of built in for the first 4 to 6 weeks after the baby's born. Extended family will come in and help, or they have some kind of support for the family. Other cultures are not quite so adept at that. So to help the family prepare and have some information about breastfeeding, about postpartum mood disorders, about changes in relationships that may take place. And then again, some of the healthcare issues that are listed here: immunizations, follow-up care, both for mom and baby, and knowing what the warning signs are, again, for both mom and baby, and making sure that they have access and know how to access emergency care. These are the indicators for step 8, that pre and postnatal education and materials are available, that they're on display so that people know that they are available. That there are questionnaires and interviews that are done that indicate that all the criteria for step 8 are included in their care. And then infrastructure requirements that are met that enable the facility to practice and provide those criteria. And that includes maybe perhaps education for healthcare providers. It may include actual facility equipment and that sort of thing. But those are the indicators for step 8. I'd like to thank you for joining us and appreciate your time today in exploring step 8 of the International Childbirth Initiative.
Bonnie, thank you so much. Thank you, Elizabeth. This is a lot of material to cover in a short period of time. I think you did a really fantastic job of giving everyone an overview. So I want to thank you both so much for your work on this. And so we have a few questions to follow up. And one of the questions that we've been hearing, because a lot of what you're talking about are components of childbirth education, and there's some concern around families and women's willingness to participate in childbirth education. Do you have any suggestions or recommendations for how we can promote the importance of childbirth education?
One of the things I think we have to consider is how we teach. I think often we teach like we do in a school classroom, and childbirth education needs to be more engaging because you're dealing with adults. There is a certain amount of presenting the information that you have to do, but there's also, you need to be doing some fun activities that help them integrate what they're learning. And I think a lot of the resistance to taking childbirth education is because we've set it up like a classroom. And honestly, if it's just information, they're going to Google that. You know, they're not going to, there's no reason for them to come and listen to you lecture. But if you're teaching them and doing the hands-on comfort measures, or letting them touch these things and see what is this like, then they're going to be more interested. Oh, this really is something that I need to know. So I think making it fun and applicable and hands-on is really key. And then I think that word of mouth will spread. I think Liz and I can both give you examples of educators whose classes are full all the time because that's how they teach. They're very engaging people. And I just finished evaluating a series for a woman in Serbia. And I complimented her many times because she has to teach online because of the restrictions in that country right now with COVID. But she was so good about, here's some information, now let's do this thing. And here's some information, but if you were in this situation, how would you use that? So she did a wonderful job of the back and forth, not just the stand and lecture.
I'm going to add to that also that some of it is getting, I want to say allies, but working with the providers in your area so that they understand what you're teaching and why you're teaching, and so that they are more likely to refer people and say, oh, you should take these classes.
Right.
These are great. I work in a hospital setting, so that's really easy for me to do is I invite them to come lecture at a staff meeting and I get them there. Or we had someone doing her doctoral presentation and she came and observed the classes and she was so excited. She had just had a baby and she said, why did I not take these before I had my baby? It really would have been helpful. And you're like, yeah, we know, we tried to tell you. But she was so excited. She went through and put posters for our classes in all of the bathrooms in the hospital and is a huge advocate. So it's also finding those people who can really help.
Mm-hmm.
Bonnie mentioned the teaching virtually. That's been an interesting thing for me, coordinating a program, because I was very resistant to it. It was going to only be for 2 to 4 weeks during the pandemic that was going to just resolve with no problem. And here we are. So I've gone now to a hybrid where I've got partial are in person and partial are virtual. And we figured out that some people that's going to be the better way to do it is the virtual class. I still think the in-person is better. That's my own bias, but we just have to be adaptable and we have to be flexible.
Wonderful. And then you touched on also incorporating the providers, and some of the audience for ICI will be providers at a facility where they may not have the opportunity to give childbirth education. They're not all seeing women throughout their pregnancy, and some of them are receiving women who in an emergency situation, and so they only have that time with them during labor and immediately before discharge to share information. So do you have any suggestions for those providers who don't have as many opportunities to provide education for how they can sort of effectively communicate with women during the limited time that they have?
Do you want me to take that? Do you want me to
Go
start with
ahead.
that one? This is where my background in health coaching really just comes to light. And if you only have a limited time with somebody, then it's not about you, it's about them. And I know Bonnie touched on that with talking about education in general and making it less that didactic, and where I'm telling you what you need to, or yeah, didactic is really the word, but telling you what you need to learn versus what they need to know. So it is asking those very pointed questions. What do you know about X? What do you think you need to know about this? And just really getting to what is their need and not what you want to get out there.
Mhm. I would add to that as well. I think when we're in those more urgent situations, we tend to speak fast. And sometimes just taking a deep breath and slowing your words down takes a little of the panic out of the situation. And then people do listen better. And I think kindness goes a long way. You know, if you are in such a hurry, or the situation is so high pressure that's coming across, and sometimes that's not avoidable. I mean, there are emergency situations that they're emergencies. You know, you have to jump right in and do what you do. But whenever possible, I think slowing down and being kind go a long way towards improving communication.
And wording, really think about
Yes.
wording. I'm just going to
Yes.
give an example that should hopefully make you really think about your wording. I had a staff member who had a prolapsed cord. And so that is an emergent situation. She was rushed into the delivery room, and her husband was not allowed to go into the delivery room because there was not time. And so the midwife who came out after did not think through her wording. And what she said was, "I'm sorry, but," was the first thing that came out of her mouth. What should have been the first thing out of her mouth is, "Everyone is safe, and I'm sorry, but we couldn't get you in here in time." And so wording is such an important and critical thing. And that goes back to slowing down and thinking about what you're saying, because this guy is about 6'7" and probably close to 300 pounds, and he nearly passed out. And this was like a 5'2" midwife. And so she did not want to have to catch him. So think about what you're saying. And that impacted him actually even into the next 2 births that they had. And so really thinking about what you're saying is such an important thing.
And actually that brings me to the next point. I wanted to just mention, Liz, because when you were talking about birth trauma, and when you were talking about ways that women could ask for something to be delayed, you know, also to flip that around to the providers when they are having that conversation, you know, and if the woman is not ready to do something, to offer that delay, I thought was also something really good that people could take away from what you were sharing, you know, rather than saying, no, this has to happen now, to at least give them the choice of timing, and at least give them options and say, okay, I really feel like this needs to happen, but, you know, I can give you some time to think about it, or, you know, to not feel that your sense of urgency should sort of override the situation, and the idea of you can at least offer those choices.
Right.
Well, this has been a really good session. Do you have any closing comments, anything you'd like to add?
It's been a pleasure.
I just think
Thank you for having us.
yeah, it's been great. And I really am so glad that we have so many passionate and compassionate people working in this field. It's something that you think, we've been having babies for as long as we've existed, and you would think that we would be at a further place than we are at this point. And so we have to constantly be taking the 2 steps forward and 1 step back. I think about Penny Simpkin, and one time I said something about, well, change takes time, and she said, but it's not going fast enough. And so, we need passionate people like her who are going to really push and drive that. And with ICI, that we're really pushing, and then thinking globally, not just thinking locally in our regions or our areas, but what's going on in other places, other countries, because the solutions are different everywhere that we are. But if we can all kind of put our collective brains together, then I think we're going to make more progress.
Yes.
They are different, but I think we're also discovering that there are things in common, and there are, takeaway messages that can cross cultures.
Yep.
And we're seeing more and more of that, the more we have these conversations. So I want to thank you both so much for presenting with us. And we hope that we can continue to work together and as well share ICEA's resources and trainings and point people in your direction if they're looking for childbirth education or for doula training.
Yes. Thank you.
Absolutely. Thank you so much.
Thank you.
And I want to thank everyone who's joined us today to watch this session. We hope that you will continue on to watch the rest of the 12 steps and that you will continue your excellent work in improving respectful care around the world.